Okay, so I'm hopeful that you can see my screen. I have with me Dr. Amy Jamieson, who is a gynecologic oncologist in Vancouver. She's joined us recently from Australia and New Zealand, and we are happy to have her and welcome her expertise on primary HPV-based screening, which they've been doing in Australia for quite some time now. So some housekeeping. Similar to our education day, this webinar is being recorded and we will post it on the Screening BC website for those who were unable to attend today or for those who could not attend. Again, similar to last time, please use the Q&A feature in Zoom to ask questions. And then afterwards, we will send an evaluation out by email, and that's how you'll obtain your CME credits. Sorry, I'm going to see what I can do so that I can actually see the Q&A. Laura, can you see the Q&A spot?
Can. So when I hover at the bottom of the screen, a bar shows up for you. If you're presenting, it might be at the top, and then there's a button for Q&A. There's no questions in there now, though.
Okay, can you still see my screen?
Yep.
Okay. We click on it.
You're not in presentation mode, but I can see your slides.
Let's go back to hover. Oh yeah, okay, perfect. Okay, our agenda for the day, we're going to review 4 new colposcopy guidelines and go through them in a case-based fashion. We'll stop after each guideline to allow some time for questions and allow you guys to process. And these guidelines are iterative, which means that as issues arise, we will continue to update them. And as new data arises, we will continue to update them. All right, so just a quick background. In 2020, the WHO passed a resolution calling for the elimination of cervical cancer. And one of their priorities was to implement HPV primary screening by 2030. We know that HPV testing identifies the potential for SIN2+ and SIN3+ at an earlier point than Pap testing, and that it's more sensitive and more objective than a cytology sample, which is read by a person. We have local data in the HPV focal study, which was a large randomized trial based out of British Columbia, which showed that women who had HPV primary screening as opposed to cytology had a significantly lower incidence of SIN3+ at 48 months. And that rate was almost halved. So where does this apply to you currently as a colposcopist? Probably at this point, the only HPV screened patients that you're seeing are private pay patients or people who come from out of town or out of province. But you will soon start seeing women in various trials. So the focal study, which I just spoke to you about, is now in its decade. And we are doing a new set of collection on the same patients. And it's called Focal Decade. So some people will have already started to see patients come into the colposcopy with HPV testing done. And then we will soon be running a pilot study of primary HPV self-collection in the underscreened, never screened women in some communities. So again, these women will start appearing in some of our local or some of our provincial colposcopists' office. So we thought this was a timely opportunity to revamp some of our guidelines and put some guidance out there so that we have standardized care across the province. Some key points. So it's just a couple new things. We are trying to move away from the confusing satisfactory/unsatisfactory colposcopy or transformation zone, partially viewed, somewhat viewed, all viewed. I really want us to be as objective as possible. So these new guidelines use the words type 1, type 2, and type 3 transformation zone. And I'll review what that is again before we get going. The other change is that in our previous guidelines, HSIL mod and HSIL severe are in the same algorithmic pathway. In the new HPV-based guidelines, ASK-H and HSIL mod are together because the positive predictive values more closely reflect each other, whereas HSIL severe is in the highest positive predictive value group for SIN3+. And then I wanted to let you guys know that we've generated tables for positive predictive values of the various HPV and cytology combinations based on American data. But some of our numbers are quite small. And again, they're iterative. We're waiting for the Australians to publish their data, and I'll continue to update these tables as we go. But I wanted to have them available so that you guys know how to manage people with like PPVs. So here's a quick review of the transformation zone. So remembering that a type 1 transformation zone is 100% visible. The entirety of the transformation zone is ectocervical. In a type 2 transformation zone, again, you can see the entirety of it, even though a small portion of it may be endocervical. Whereas in a type 3 transformation zone, you cannot see all of it. You may be able to see some of it, but the most important thing is that you cannot see all of it. This is the current HPV triage algorithm, and this is the algorithm that's going to be used to determine who comes to colposcopy and at what point they come to colposcopy. So let's go through this because I think it's important, and we're going to look at it again with every case to hammer home these points. HPV test screening is every 5 years as compared to every 3 years for cytology-based screening. Women who screen negative go for another HPV test in 5 years. Women who have a positive HPV test for type 16 or 18 are getting referred straight to colposcopy, which means that they arrive in your colposcopy clinic with no pap test. This is really important because you are going to be required to do a pap test at their first assessment. It's really important to help you triage the patient to know what to do with their biopsy results. So again, I'm going to bring this up numerous times so that we all remember. HPV 16-18 comes straight to colpo with no pap test, whereas HPV positive other, they have to go to their family doctor to get a pap test. Any cytologic abnormality is coming to colposcopy. So ASCUS, LSIL, and beyond, they're coming to colpo. Whereas if they're normal on pap test, they get screened again at 12 months. If HPV is persistent, they're coming to colpo regardless of the pap test result. So you need 2 positive HPV others with normal cytology to get into colposcopy. Okay, so after that pretty basic intro, we're going to get into some cases which will review the new algorithms. So the first case, very simply, is a 30-year-old who does a primary HPV screen at home, and it reads HPV 16 positive. So again, remembering this triage algorithm, an HPV positive pap or an HPV positive self-collected sample is being referred straight to colposcopy. So now this patient is in your colposcopy clinic, and the first thing you're going to do is do a pap test. And then you're going to continue on with your colposcopy as you normally would. Okay, the arrow, cytology obtained at colposcopy. So in colposcopy, you did your pap test, you saw a type 1 transformation zone, your colposcopic impression is CIN1, you did your directed biopsies and your ECC, and again, I'm highlighting that you need to do a pap test. Your cytology result returns as LSIL, and your biopsy result is CIN1. Here are the PPVs that are of significance here. The PPV of immediate CIN2+ in this HPV 16 group is 22%. Of CIN3+ is 11%. So 2 out of 10 patients will have a treatable lesion. So then, because your pap test was LSIL, you're going to look at the LSIL algorithm. Okay, so here we are, HPV 16-18, you did your pap test, and it was LSIL. Remember, that it was a type 1 transformation zone, and your biopsy showed CIN1. Follow the algorithm down. You're going to repeat colposcopy in this patient in 6 months. And the reason that we chose this as opposed to discharging them, as we would in our current algorithm with concordance between L-cell cytology and a CIN1 biopsy, is that in the presence of a high-risk HPV, the provincial colposcopy leads felt that it would be prudent to see the patient one more time to ensure that a higher grade lesion wasn't missed prior to sending them to an HPV test in 12 months' time. Okay. And I want to remind everybody that a transient HPV infection is not a risk factor for CIN3+. It's the persistence of that HPV infection that's the risk factor, which means that you're not discharging this patient to a pap test in 3 years. You're not discharging them to routine screening, which would be an HPV test in 5 years. What you're doing is discharging them to a repeat HPV test in 12 months, which means if they're persistently HPV positive, 12 months later, they're coming back to colposcopy. So you can feel reassured that discharging them is safe and that they're going to wind up right back in your office if they're persistently HPV positive. And the reason to give somebody 12 months is because an estimated 67% of patients are going to resolve that HPV infection. And if they don't, then again, that's a high-risk patient. This is what the PPV tables look like. We're going to make these look nicer and send them out to everybody so that you have them as a reference. They're split up by cytology. So this was an L-cell cytology patient with an HPV 16 positive result, and we've provided immediate risk PPV for both CIN2 and CIN3, and 5-year risk PPVs for both CIN2 and CIN3+. So hoping that that's helpful for you when it comes to decision making. The one thing that I want to point out before we move on is that with normal cytology, an HPV other patient is not coming to colpo because look how low those risks of CIN2 and CIN3+ are. The referral threshold that we use is 3.5% to 4%. So with an immediate risk of CIN3+ of 1%, that's why that patient's not coming to colposcopy with other. Whereas with 16, 18, the risk is high enough that we wanted to see them right away, regardless of what their cytology shows. Okay, so I'm going to go back to this also ask us algorithm and pause and allow a couple minutes for any questions.
Can you see the Q&A now, or do you want me to let you know if some come up?
I can see it. Okay. So I'm not seeing any questions pop up, which means that this is super clear. And so, okay. And again, like with these algorithms have been reformatted, so they're going to look a lot nicer before we send them out properly. Oh, question. All right. Is the plan to have HPV self-collected for everyone in the province eventually, not done in the office? Thanks. Yeah. So that is the goal, but the first step is to do the pilot to examine the feasibility and the uptake and patient satisfaction, et cetera. But that would be the goal, is to have it as a kit that gets mailed to every eligible woman's home, and they self-collect, put it back in the mail, and it arrives at the lab, and then the referrals get processed and the letters get sent to patients and providers. Okay, so we will then move on to our next case.
Okay, so case number 2 is a 45-year-old woman who does a self-collected swab at home and is HPV 16 positive. So again, because she's HPV 16 positive, she goes straight to colposcopy. So at the colposcopy appointment, she'll need to have cytology obtained at that visit. We're just highlighting that again. So at your colpo, she this woman has a type 3 transformation zone. Your colposcopic impression is normal. You do your biopsies, ECC, and your pap test. So your cytology result is ASCH, and your biopsy result is negative. So here are the PPVs for an ASCH cytology with HPV 16 positive. For CIN2+, it's 41%. For CIN3+, it's 28%. So this is the algorithm for, and as Dr. Proctor's already mentioned, ASCH is now combined with H-cell moderate. So this is this algorithm. So remember, the patient did this home swab. She was HPV 16 positive. At colposcopy, the cytology was obtained, which was ASCH. She had a type 3 transformation zone, and your biopsy was normal. So because of the type 3 transformation zone and the concern that you may not be seeing the lesion because it's in the canal, and because of the PPV being for CIN2+ being 41%, so reasonably high, with a type 3 TZ, even with a normal biopsy, there is the option of doing an excisional treatment. Again, but thinking the lesion could be in the canal, a 41% chance of CIN2+. However, obviously, depending on the patient's age, fertility wishes, etc., there is also the option to do a repeat colpo with an HPV test and cytology in 4 to 6 months' time. So obviously, a type 3 TZ with an ASCH HPV positive, these patients are not being discharged. Either offer them an excisional treatment or a repeat colpo in 4 to 6 months' time. So should you wish to proceed to the repeat colpo in 4 to 6 months, if by then the patient is now HPV negative and your biopsy is normal or CIN1, at that point they can be discharged. But again, they're not discharged back to a 3 or 5 yearly screen. It's another HPV test in 12 months. If they're HPV positive at that follow-up appointment, but their cytology has now been downgraded to either normal or LCL or ASCUS or a CIN1 on biopsy, these patients can also be discharged, again, being reassured that they're going to have a repeat HPV test in 12 months. And if they're still HPV positive, they'll come back to colposcopy. And obviously at that repeat assessment, if they're HPV positive with ASCH or higher, then they need an excisional treatment at that point. So again, here are the PPVs for ASCH, and for this patient was HPV 16 positive. The immediate risk 40% for CIN2+ versus 25% for 3+. Okay, so we'll go back to this algorithm and see if there's any questions about this one. Again, must be super clear.
We're all experts at following algorithms, I think. Okay, excellent. Moving forward. The third case is a 35-year-old who has an HPV other positive result on a self-collected sample. So back to our triage algorithm, this patient would go to their primary care provider for a pap test. And the pap test in this scenario shows HSIL severe. But again, remember that in this category, any cytological abnormality is going to colposcopy, okay? But in this scenario, we made her have a high-grade pap test. So with an HPV other, you don't need to do that pap test in colposcopy because it already comes with the patient. So, but in colpo here, you have a type 2 transformation zone, which again, remember, means that you can see the whole transformation zone, even though a segment of it may be endocervical. You thought that it was CIN1, and your biopsy actually also shows CIN1. Now, the PPV of immediate SIN2 plus with HPV other and HSIL severe is almost 60%. Okay, so this is the highest risk for a squamous lesion, and the highest risk for an immediate cancer actually is with high risk HPV positivity and a high grade PAP. So in this scenario, you refer to your HSIL severe algorithm. And remember that you could see the transformation zone. It was a type 2 transformation zone, and your biopsy showed SIN1. So what you can do, if you're interested, is a cytopath review to confirm HSIL severe. But what you also need to do is assess the vagina to make sure that you're not missing a vaginal lesion that could explain the high-grade PAP test. But even in the absence of a vaginal lesion, there is no scenario essentially where you're not going to be offering this patient an excisional treatment. Okay, so even though you thought it was SIN1 and it was SIN1, because of the high positive predictive value that's associated with the combination of an HPV high-risk strain and HSIL severe PAP test, this patient is going to be recommended to have a LEAP. Okay. Basically, the only way you're going to get out of doing a LEAP in a patient who's HPV positive with HSIL severe is if on cytopathological review, your cytologist downgrades it. So they're telling you, oh, actually, it doesn't look so bad now that I'm having a second look at it. And as we know, that's a pretty rare scenario. Okay, so these are the PPVs. Look at how high those are. The immediate risk of SIN2 plus with HPV 16 is almost 80%. Okay, and I wanted to include this caveat because it's important to keep in the back of your mind that in the American data, they do not split up HSIL into HSIL mod and HSIL severe as we do here. The PAPs are just reported as HSIL, which means that these PPVs are overcalling HSIL mod, but undercalling HSIL severe. So likely the PPVs are actually much higher than 76% because in the BC world where our cytopathologists distinguish between HSIL mod and HSIL severe, in this scenario, the PPVs are quite high. So we wanted to have it as a separate algorithm, reminding everybody that you're doing an excisional treatment in basically every scenario. Unless I guess the vagina is what's harboring that mutation, that dysplasia, and the cervix looks okay. Okay, some questions. Yeah, so Elaine has said, when requesting the cyto review, I've never had any results downgraded, so I have stopped asking for them. So a lot of people, Elaine, feel that same way. We got some feedback from our colposcopy leads on that exact scenario, but we still wanted to provide the option just in case you really felt confident that there was no way you were missing a high-grade lesion, that could be something that you could consider. And it takes 4 weeks for the feedback. Yes, we know it does take some time. Okay, Anne has said, can we skip colpo if PAP is severe and high-risk HPV? Could we just see and treat? Absolutely, you can. And you will notice that, especially with this pilot, that this is the pilot's population is underscreened, never screened women. So this is a person that you absolutely don't want to lose to follow up, because we already know based on their history that they have a tendency to not come for screening. So if I saw that a woman who was underscreened or never screened in colposcopy with HSIL positivity and HSIL severe, I would offer them a LEAP right away. Okay, Vanessa, how do you recommend triaging HPV positive patients? Do you want them seen within 2 months? That's a good question. What we would recommend is that if the patient is HPV 16, 18 positive and they come with no cytology, that you see them within 4 weeks, because you don't know what their cytology is. You don't know if it's going to be severe or low grade. So just try to see them within 4 weeks. Whereas if it's an HPV other positive patient and they come with if they come with cytology, then you would triage based on what their cytology was. So an LSIL patient can be seen within 12 weeks, whereas an ASK-H patient you would see within 8 weeks. So similar to before. And then I also wanted to bring up the point before we move on that the lab is shifting gears, and what they're going to do is that any pap test that you as a colposcopist do is going to the front of the queue, which means that you should have that pap test resulted very quickly, because I know that that affects your management. I know that we don't know what to do unless we have that pap test result, and we don't want to be waiting 4 to 6 to sometimes 8 weeks for a cytology to be resulted. So this is something that's being newly implemented, that colposcopist obtained pap tests are going to be resulted very quickly. And I hope that that's helpful.
I guess just another thing to mention is the see and treat for the high-risk HPV positive HL will only be relevant to the high-risk HPV other types, because the 16-18 will not be coming with their cytology.
That's true.
So it's actually, unfortunately, yeah, that the see and treat won't be an option for the 16-18 positive, because we're not going to have that PAP result when we first see them.
That's true. Good point. Okay. So we're going to move on to our last algorithm here.
So the last case is a 40-year-old woman, self-collected swab at home, reveals HPV 18 positive. So again, because it's 18 positive, she's referred straight to Colpo. The colposcopist has to obtain the cytology at that first visit. So at Colpo, she's a type 3 transformation zone. Your colposcopic impression is of a high-grade lesion. You do your biopsies, ECC, and your PAP. So your PAP result is atypical glandular cells, NOS, and your biopsy result is CIN1. So the PPVs for atypical glandular cells, for CIN2 plus and HPV 18 positive, you can see it's 39%. For CIN3 plus, it's 33%. So we just need to point out that, again, because these numbers are using the American data, and the American data groups together atypical glandular cells, NOS, with atypical glandular cells, favor neoplasia, and AIS. So we know that for a PAP that is atypical glandular cells, NOS, these PPVs are probably going to be an overestimate. We know that they'll probably be lower. But for favor neoplasia and AIS, it will be the opposite. We know that these are probably actually falsely low, because from BC data, where we do separate it, we know that when you have an atypical glandular favor neoplasia, the PPV for CIN2 plus is more than 70%. So again, this is something we'll be able to update when the Australian data comes out, but just keeping in mind that these three are all grouped together with these numbers. So here's the algorithm for atypical glandular cells. So just like the current guidelines, it is separated based on whether it's NOS, abnormal endometrial cells, or AIS or favor neoplasia. So remember, this patient, her PAP was NOS, and she had a type 3 transformation zone. And her biopsy was CIN1. Because of the atypical glandular cells and a type 3 TZ, so being concerned that there could be a lesion in the canal, even with a normal or CIN1 biopsy, these patients are not discharged. So they come back for a repeat Colpo HPV test and cytology in 6 months' time. Obviously, any patient who are high-risk HPV positive with a PAP showing AIS or favor neoplasia, these patients all get treated. You will see the only patients that are able to be discharged from Colpo that have an atypical glandular PAP are patients that are atypical NOS and have a type 1 or type 2 transformation zone with a normal biopsy. So this is the only scenario where a high-risk HPV positive atypical glandular PAP will be discharged, as if you know they've got a type 1 or type 2 transformation zone, a normal biopsy, these patients can be discharged and have an HPV test in a year. Everyone else is either treated or brought back again in 6 months' time. And again, here's the summary of these PPVs, and just remembering that these numbers, because they're combined, For the NOS, they're probably an overestimate, but for the FAVR neoplasia and AIS, they're certainly an underestimate. And we know, again, from our data that high-risk HPV positive in a FAVR neoplasia cytology, the PPV for CIN2 plus is greater than 70%. So I'll bring back that glandular algorithm just to see if anyone has any questions about that one.
So this is a good question. How will patients access HPV testing if they're discharged from colposcopy? Will they have something mailed? Does the GP do it? So it will depend on what scenario the patient is currently having their HPV testing done in. If they're a trial patient, then it will get provided to them in the same way that their initial HPV test was provided. So if they're a pilot self-collection patient, it will be sent again through the mail in 12 months. If they're an HPV focal patient, then they're going to have it done by their primary care physician. And if they're a private pay patient, then I think currently we're not actually recommending that they get an HPV test again because we don't have a good way of following them. But who is educating the primary providers about this? We are. And Laura can answer this better than I can, but there have been numerous meetings with the primary care providers across the province about the rollout of these trials and their feedback on how to proceed. There's going to be a lot more education that's required, we know, moving forward. Will physicians have the option to do the HPV test in their office when they see patients? It might improve uptake. So that's currently something that we're looking at in the pilot population, that if a patient comes into their OB or gynae or family care doc and they're a trial patient, that their actual provider will also have that sample and will be able to, or will have the kit and will be able to help them do it themselves. But we really want patients to do it themselves because we want feedback from the patients on how good were the instructions and how did we tolerate it and what can we do better. We'd prefer that the patient does it themselves in the presence of you as a physician, as opposed to you doing it for them, if that makes sense.
Lily, I think when we get started with the pilot, our intention is to just get going with the mailed process for sending the kits out. But I also see great value in terms of uptake at that just-in-time visit to offer a kit in the office. So we will be looking at that, but probably not right away in the pilot. And when we were developing the business case for provincial rollout for self-collection of HPV for primary screening, we did consider that we would have kits in the offices and we would expect that a certain portion of people would participate in that way without needing to get any sort of mailed correspondence from us. So it'll be, we'll have to roll things out a little bit at a time and see how we go, but I think those are all good ideas.
Okay, perfect. Thanks. That was really clear. Elaine has asked, can you describe how the self-testing is done? How far into the vagina is the swab placed? Laura, do you have that picture from the patient handout that you can share? Do you have it handy? It would take me a while to find it.
Yeah, let me pull it up. You could, if there's another question, you can go on to that, but we could come back to it certainly at the end of the talk, and I'll grab that.
Perfect, yeah. Okay, the next question is, will PAPs be liquid-based at Colpo? Nope, they're going to continue to be how they currently are. The only liquid-based PAPs that are getting done right now are if the patient is enrolled in HPV focal and are having their decade follow-up. That's a liquid-based HPV collected sample, and those patients will actually come with reflex cytology regardless of what their HPV result is. But that's a very specific and not a large population, and not how we intend to roll things out provincially. So another question is, should we be offering women outside childbearing years LEEPs if they are HPV positive? So that's a good question. I think it depends on the duration of HPV positivity and then obviously the cytology that comes along with it. I know that we often have for me anyway, the most difficult patient scenarios are in women who are persistently HPV positive with no cytologic or colposcopic abnormalities. And you continue to have to see them every 12 months and you don't really know where you're going or what you're doing. And even more difficult in women who've had lots of LEEPs and you actually can't do a proper assessment of the transformation zone at all, and your biopsies are inadequate half the time. So I'll just take the opportunity to say that and remind everybody that really it's the persistence of HPV and the persistence of the same genotype which makes a woman a high risk for getting dysplasia. So somebody who's HPV positive for 16 one year and then HPV positive other the next year is less high risk than someone who's been HPV 16 positive for 2 or 3 years in a row. And there was a recent study published out of Sweden where they followed women who were persistently HPV positive, and they followed them basically out to completion. And they found that there were only 2 scenarios in women who were HPV positive. Scenario number 1 was that they got SIN2+, and scenario number 2 was that they cleared HPV. And the median time was around 7 years. So I know that's not super helpful, but in around 7 years, you're going to know if your patient has SIN2+ or if they've cleared the virus. And if this is a woman that you can't assess properly, like colposcopy is difficult, they have a scarred os, you have to take them to the OR every time. I would say that if after 3 to 4 years, they're still HPV positive, that a hysterectomy is warranted. Just because we know the natural history and we know that they're going to develop a lesion.
I'm ready to show a device. I have one here. Do you want me to do that now?
Do that. I'll stop my screen share and allow you to show us what it looks like.
Can you see my instructions or
Yeah.
my email? Look at the instructions. Okay. I have 2 screens. I'm never certain. So this, I'll turn my video on and I'll show you one as well. But this is the flock swab device, and there's a little line there, and the woman holds the swab at the line and then inserts the swab to that point where to touch her fingers, if that makes sense. So I can, but I'll show you. Hopefully you can see me. The light might not be great in here. So this is the flock swab container that we're using. These aren't yet approved by Health Canada, but that's in process. So you might not see this particular style of device, but the swab itself is obviously used in many different things. So I'm just going to show you, there's that red, hopefully you can see it, the red line on there. And so it's held at that point. Any other questions about that?
That's really helpful. And then the instructions say that it's rotated a certain number of times in one direction and then the other direction. And then you take it out and you put it in the tube.
Yeah, we like this one because it is, simple to take apart and put back together. There were a few things that, a few other devices and stuff that we looked at, but I think this is just straightforward, and the packaging for it is nice to come back in the mail. It's nice and sturdy.
Okay. So Elaine's next question is a wooden spatula okay for thin prep HPV test that we're doing for LEEP follow-ups? My clinic ran out of the plastic spatulas. I don't actually know the answer to that question. But can you email it to me, and then I can ask the screening folks about that, and maybe we can just get your clinic some more plastic spatulas. Okay, and then the next question is, oh, they are in order. Okay, good. I don't know, Laura, do you know if they can use the wood ones?
I don't, but I can fire off a note to Brenda Smith. She'd be able to advise on that. So I can just do that, and I'll try and copy Elaine on that email,
That's
and
great.
then everybody's connected.
Okay. And then if HPV is negative but is closed,
Yes, maybe.
how can we guarantee that HPV in OS is also negative, i.e. vaginal and cervical concordance of HPV? That's a good question. Okay, so we can sort of extrapolate. There have been now lots of studies which have looked at HPV self-collection as compared to physician-collected samples. And there is good concordance, which leads us to believe now by extrapolation that women are not going in their own cervical osses when they are self-collecting, which means that a vaginal sample is just as good as an intra-os cervical sample of HPV. And again, numerous studies which have now shown good concordance in patient-collected versus physician-collected samples. Okay. And then Elaine, yeah, I don't know about the wooden spatula, but that makes sense that some of the wood might invalidate the test or make it falsely negative. I'll share my screen one more time. We're getting near the end of our hour. I am not seeing any new questions. I hope that this was helpful. What we're going to do is send everybody again the newly beautified algorithms in the BCCA color palette. And then I'll also send out the table of PPVs. I'm not going to publish the table of PPVs because the data is not perfect, and I'd prefer to have a couple other publications to base those PPVs on, but I'll send them to you guys so that you have them. And they're iterative, like I said, so if any feedback, if anything is not clear, if you want anything amended, please just email me and I'll see about changing it and making it easier to understand. And then what we'll do is we'll review our data in a year or two and see, for example, how necessary it is to do repeat colposcopy if you have a SIN1 biopsy. How much are we actually adding? And is it feasible when we turn to doing provincial HPV screening, because we know that our colposcopy clinics are going to be overrun in the first couple years, as this is a test that's going to pick up a lot more women initially? Are we going to have the capacity to see people again in 6 months, or is it safe to offload them to our family care providers to do another HPV test, or for patients to do it in the mail? Okay. Oh, one more question. The PPV algorithms are interesting. Is it reasonable to use this information to help us make case-by-case recommendations for patients that fall outside the algorithms? Absolutely. That's why I'm providing them, is I would like you to have the most amount of tools in your toolkit to be able to make the most educated decisions based on current literature. But just remembering that some of the cytologies are different than the ones we report. So again, the HSILs are grouped together and the AGCs are grouped together, and that we'll update it when we get the Australian data, hopefully in the next year or so. And then of course, our own data we'll use eventually. Okay. Well, thank you everybody for coming.
Yeah.
Thank you, Dr. Jameson, for being available and for helping formulate these algorithms.
No problem.
We hope you have a lovely Wednesday.
Thanks, Lily. Have a good night.
Yeah, you too. Bye.